Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of the optometry field through dynamic insights, practical clinical tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in eye care. Our mission is clear: empower eye care providers with the knowledge and tools needed to provide exceptional patient care. At Advanced Patient Care, we are dedicated to elevating eye care one episode at a time. When we talk about post-operative course, obviously it depends on what we're doing and what surgical procedure they have. But Zach, kind of walk us through what your typical post-op course is looking like for some of these eyelid patients.
Yeah, so I think this is probably the most important thing to patients, like you said, Deb. It's how quickly can they get back to doing their normal life and how long are they going to be bruised and swollen? This is the thing on the top of most people's mind and how much discomfort goes along with the whole process. And so kind of my general breakdown for patients goes kind of like this. I'll just tell them, this surgery, depending on what it is going to take about X long, upper left 30 minutes. If we're adding a lower bleph, maybe another hour and a half or so. We're going to do patients under kind of a twilight sedation oftentimes, so they're breathing on their own. They're not having to have a tube down. They get to be awake for surgery, just relaxed and comfortable and not caring. And then we have our local anesthetic, of course. They're going to go home that day, so there's no staying overnight or anything like that. I tell them they're going to need a ride on the day of surgery because they're not going to be able to drive because they're going to be a little loopy from the anesthesia. But then they're going to go home. I like to have them essentially just take it easy. I tell patients, take it easy for a week. Don't do any heavy lifting, which I specify to them as try not to be picking up more than 10 to 15 pounds. Try not to be bending at your waist. Try not to be straining a lot. Anything that's going to increase the blood pressure to your head that may promote bleeding, which we don't want, I tell them to avoid. So light activity, going on walks. They can go on drives after, after the day of surgery if they feel like it. Things are going to be a little bit blurry if we're using ointments and that kind of thing. The eyes might feel a little bit dry right after surgery. That typically goes away as the orbicularis muscle wakes up. I warn them of that. We give them artificial tears, but we have ways to, during surgery to make sure they're not going to develop permanent dry eye by doing skin pinching and that kind of thing to make sure they're not going to have lag ophthalmos. But I tell them about a week of easy life. The bruising and swelling, I tell patients, may last a week or two. It depends. If you'll be more aggressive doing the ice and the cold compresses, it'll go away faster. So what I have patients do is for the first 3 days, 20 minutes out of every hour while awake, I have them ice. And so I will tell them, if you're awake, sitting around watching TV, take your ice pack, 20 minutes on, 40 minutes off every hour while you're awake. It's a lot of icing, but I find that the patients that do it bruise and swell far less than the patients that don't. And I think they appreciate that at the 1 week visit. I'll have them come back at the 1 week and we'll take out sutures. I'll typically use non-absorbing sutures because I feel like it heals better. It's less inflammatory to the skin. It tends to, I think, give a little bit nicer results. And so, especially in our cosmetic patients, we want that. But we'll get those sutures out at 1 week. And then I let patients go back to doing their normal life. So after that 1 week visit, I say you can go back to doing your normal stuff, no restrictions, maybe ease back into really heavy working out if you're into that kind of thing. But otherwise, you can pretty much do all your normal stuff after a week. The only thing I don't like patients to jump right back into is going underwater. So submerging your head in pools, hot tubs, and lakes. I ask them to try to avoid it for a month if they can. You can get weird atypical mycobacterial infections in the wounds from fresh water. I let them shower, but I try to have them not do a lot of swimming for that first month or so. But other than that, it's essentially a week of taking it easy, having some itchy eyelids, and then they're back to doing their normal stuff. The bruising and swelling will tend to fade over that second week. If we've paired a laser with the surgery, like a cosmetic surgery, I find that has faded on most patients by about 7 to 10 days. It depends on how aggressive we're going with the laser, but with the CO2 laser, it's the redness and pinkness is mostly gone by that 1 week visit. There'll be a little residual that goes away over the next few days. Um, Most of my upper bleph patients, we don't use any antibiotic ointment. I find you don't need it. I think you and I use a similar technique with a running subcuticular suture with steri
Yeah.
strips, so I don't need ointment. They, don't have the risk of allergic reactions to erythromycin and that kind of thing. It's one less thing for them to do. The infection rate with this is exceedingly low because of how well the eyelids are vascularized, and how well it heals. And so infections are very low risk with these surgeries. They're possible, but very treatable if they do happen. So that's kind of the general picture I try to give to patients. If I'm really want somebody that's not getting, the extent of the bruising and swelling, I say, you may have a black eye for a week or two. People bruise differently. That's normally in our older patients. I find our younger patients heal much quicker. And then sometimes at 1 week, it looks like they haven't even had anything done in terms of the bruising and swelling they have. But that's kind of what I give patients to expect. Is that kind of similar for you or?
I love that. And you and I have, that subcuticular running stitch down where, it's actually one long suture of proline in the uppers and even the lowers, that you can actually pull out at 1 week. Sometimes we'll put in safety sutures, just to make sure if they rub the eye or if they took off the steri strip accidentally and the whole proline suture came with it. We're trying to safeguard against that. But for the most part, patients tolerate that type of technique a little bit better, because it's easier to remove instead of taking out stitch by stitch as far as a single interrupted stitch. And then, as Zach alluded to, it's really at 1 week they can go back to normal activity. But another thing I would add to where I'm a stickler for a couple weeks is makeup, directly on the eye itself, because they still have an incision there, and so we want to make sure that that incision heals. Scars are different in everyone, and we always ask, how do you heal? Have you ever had prior surgeries? Did you develop any bumpy scars or thick scars? Because I really like to know that beforehand, just so that we can really keep up on how they're going to heal. But a scar can take up to a year to fade, and so I'm really asking them to avoid sun exposure, to wear their sunglasses, to wear a hat, just to protect that scar. And then at a week, remember, we're taking off the steri strips. And so at a week, they ask, okay, what else can I use to help with the scar? And so there's scar recovery gel that they can put on, as well as vitamin E. Do you have any other recommendations, Zach, for scars?
Yeah, no, I think that you bring up a good point with the scarring because that's also on everybody's mind is how is it going to heal? Fortunately, the eyelids heal fantastically, and I think this again goes back to the blood supply being very good one, but also it being the thinnest skin in the body. It tends to heal beautifully. Brow skin is of course less forgiving. It's thicker. It can scar worse, but the lids tend to heal fantastically. And I'll tell patients that ask about or are worried about scars, you can't make an incision on the skin without there being a scar, so to speak, but oftentimes they heal so well that they become imperceptible. And sometimes even at a week, it's hard for us to really make out a horrible scar. And I think that a lot of that owes to that technique with the running subcuticular suture. I find we get a lot less inclusion cysts and a lot less of that bumpiness along the incision line with it. If it does happen or patients really want to just, go at it with something, I think, like you said, vitamin E oil is good. And then there's a good gel called just Scar Away Gel. And you can buy it over the counter at most pharmacies for $13. It's made for other parts of the body, so it comes on a big roller ball. It's not great for the eyelids, so what I'll tell patients to do is just cut the back of the tube off, use a Q-tip, put it on twice a day, and then saran wrap the back of the tube so it doesn't dry out. It's 100% silicone gel, which is what's been shown clinically to be the best for scars. It's cheaper too. We have other options that are much more expensive. I tell patients just go get this. It's cheaper. It's going to work, the best. So that's what I'll have them do most of the time is scar away gel, vitamin E oil. And then, like you said, staying out of the sun. The sun can hyperpigment scars or hypopigment them and change the colors they heal. So avoiding the sun to the incisions is good. And then especially if we've done laser, that's going to be extra important. But yeah, I find that the lid incisions just heal fantastically for the most part. Like you said, it can take months to a year for them to heal. But if patients are having a little bit of bumpiness or don't like the look, we can also do resurfacing laser along the scars to kind of help them along the healing process sometimes. So we'll occasionally do that as well. I know you do that some too, I think.
Yeah, I love that. And even if they just want a little touch up or, a little extra tightening, sometimes we don't have to go back and, take more skin. There's only so much skin that you can take of the upper lid and the lower lid, that can cause more harm than good, when we're talking about leg ophthalmos and talking about ectropion and beyond. And so we have to be careful about that. And my attendings always said it's better to be conservative than overly aggressive. You can always go back and take more. And I think, Zach, we get pretty good about knowing how much skin to take, and we have, again, some rules of thumb that we use to stay within those confines. But, everyone's different. And, that's where we just really want to follow these patients to make sure that they're recovering well, especially, if we're doing multiple procedures on the eyelid. It's really important, like Zach, you mentioned, sometimes it can unmask or uncover another problem. And that's so true with ptosis. Sometimes, you sit the patient up in surgery and it looks just absolutely perfect. And then a month later, or even a week later, they have some asymmetry. And so sometimes it's like a teeter-totter effect, or sometimes you don't get that perfect, contour of the eyelid. And so those are things that we really want to look at. So if some of your patients are not happy, we need to know about that, because again, it's so important when someone looks in the mirror to make sure that they're happy with their results, that they feel symmetric. It's kind of, beauty is in the eye of the beholder, and sometimes they'll point out things that we don't see. And so it's just so good to collaborate and to take care of these problems early.
Yeah, exactly. You bring up a good point about ptosis, Deb. It really is probably the hardest thing I would say with what we do, other than just really artistically getting a lower bleph right, is ptosis. It's a very complex problem, and there's more moving parts to just going in, lifting a lid, and it being in the right spot. There's getting the contour and the shape of the lid right. Patients will notice contour changes far more than they will be bothered by height abnormalities. And the other thing that really bothers them is asymmetry. So patients, by and large, would rather be ptotic on both sides a little bit rather than be fairly open with slight asymmetries. Asymmetries are really what bother patients the most. And unfortunately, like you said, there's other things that go into it, like Herring's reflex, where you lift one eyelid, the other will come down. So these little micro changes can be from inputs to the brain on where the lid position will end up. And like you said, we can look great on the table week one. It can look low at week one or perfect, and it can change over the course of the next few weeks. And so it can sometimes take going back and tweaking things just a little bit. I will work with patients and try to get them to a good spot. If we need to go back and adjust something, we can do it. And ptosis is where that sometimes becomes necessary, because it's just such a tricky and finicky thing to get right.
Yeah. And Zach, I so appreciate your heart. And, that's one thing, we just want to do the right thing. And we want to make sure that, we provide our expertise and that we're there, if patients need additional hand holding. But, it's just such a fun field. And I really hope that you all have enjoyed this last kind of segment and this last podcast about all things eyelids. And we just so appreciate you all. And please reach out if you have any questions.
Yeah, it's been fun. Want more? Schedule your personalized mini fellowship at Vance Thompson Vision today. Immerse yourself in hands-on learning, gain insights from our experts, and take the next step toward excellence in eye care. Remember, the world of eye care is ever evolving, and so are we.